right, it's been an incredible day listening to what we can do as it relates to clinical decision support, AI, working together as teams. So I want to take a moment and have a better idea of who's in the room. Okay, can all the nurses raise their hands? All right, all of the physicians, social workers, case managers, pharmacists, operators. All right, I'm going to tell you a quick... Dietitians, yes, dietitians, so incredibly important in this patient population. Thank you for that, because it truly is a team sport to take care of patients, take care of communities, and really advance their care. Early in my career, I had a dream about the end of the world. And in that dream was the social worker and the case manager that I worked with every day when I was at St. Luke's as a hospitalist. And what I remember about that dream, which has been so interesting, and what made me think about it today was the conversations we're having, but I remember that there was a clock, there was a red and white gingham tablecloth, and the three of us were sitting around that table. And I think it has a lot to do with the fact that early in our careers and when we're taking care of a patient, it really is that interaction between what's happening clinically and also what's happening for that patient beyond the four walls. And so we're going to talk more about that. But I'm going to start by taking you down the road of what it was like clinical decision support in the early days. So for many of the clinicians in the room, especially the physicians, you'll remember you had your white coat, 2 pockets on the outside at the hip, 2 pockets on the inside, a pocket at the top. Medical students had the same, and you stuffed as much as you could in those pockets. You had no choice. You had a Sanford to let you know what you were going to do from an antimicrobial support standpoint. You had your wash manual, because in those days, if you were the medical student or the intern, and then later even the second and the third year, the upper level resident, you were responsible for the full clinical exam of the patient, including ophthalmic exam, the whole fundoscopic exam. You were also looking at tympanic membranes. You were recording all that. Full review of systems, a differential diagnosis, and the wash manual helped you to do that. Then when you wanted to get a little bit more detail as it related to the medications the patient was on, you had your pharmacopoeia that was in your pocket. And then, of course, if you were on a pediatric rotation, you had a Harriet Lane. For the nurses in the room, you'll remember during this time that chained to the med cart in the drug room, in the medication room, was a book to tell you about medications. So it was very manual process. And then we advanced. This is when we had multiple computers at the computer station, one that would be outwardly facing for the clinical staff to use. You also had some that were on the walls. During that time, we were starting to have more. At some institutions, you might have had some in the rooms. So at least those books that used to be in your pocket were now available online. And if you had a device, then you could also get those resources online. Then we went to integrated within the electronic health record, and to the comment that was made earlier in the day about the things that you had to do, this was clinical decision support that you had to do. This was before we got really smart and decided we weren't going to have every alert be there. Every alert was there. Every drug-drug interaction, every possible renal dose you needed to look at, every possible rule that the institution had decided that would be there, or whatever pre-populated clinical decision support that was built into the record, electronic health record, came up and stopped you in your tracks in the workflow. But what if, which is a question we've often asked today, what if you could decide what clinical decision support was going to look like? We've talked a lot today about what's most important to this patient population. We've talked about the need to have a better understanding of who they are as a patient. We've talked about the need to have a better understanding of all the parts within their personal life that impacts how they're relating to the disease treatment, how they're doing as it relates to dialysis. We've talked a lot about what it means to be part of the clinical team, whether you're the dietitian, the pharmacist, the social worker, the case manager, the physician, the renal technician, whoever you are in the care of that patient, what does it mean? And if you're an operator, what does it mean? Right now, what we know is that if you talk to anybody across the healthcare space who's taking care of patients or developing the next technology for patients, there are three parts of it that are really important. What's the operational efficiency and how will it improve it? What is the clinician experience, no matter who that clinician is? And then what is the patient experience and what is the access? So let's talk a little bit more about that as we have today. So if you look at clinical workflows and automation, we've talked about every possibility today. It is not just something to talk about, it is a reality. So right now we have generative AI tools that can help bring all the information together, as we saw earlier. It can analyze, it can characterize it, it can plot it out for you. Now we're at the point that if we take all of that information, all these disparate data points, could be coming from an electronic health record, could be coming from a clinical health needs assessment in the community, could be payer data. What if it's data from an electronic device within the patient's home? What if it's information that's in the clinic that also has to get to the acute care setting, vice versa? Dialysis, outpatient dialysis back to acute care setting and vice versa. What if it's information that comes from an app that is helping the patient make dietary choices? You can bring all of that together. All of that information comes together, and going beyond the summary and going beyond a plot, it becomes actionable. Insights that are right there at the fingertips of the clinician, the social worker, the pharmacist, the dietitian, when you need it, to have an interaction with the patient. And the goal of that is that that interaction is not an up and down, it is a face-to-face, and it is meaningful so that your time with them is definitely providing them with the information they need to take better care of themselves outside of your four walls, and also helping to have a healthier community. Let's go to the next. Prior authorization automation. So to the point earlier, none of us went to school to learn insurance, but boy, it became really important. As a hospitalist, I had to understand it inside and out as I was taking care of patients, sometimes that were from underserved areas or didn't have full coverage or didn't have any coverage. It was important that I understand how their care would be delivered to them when they left the hospital. It's important to all of you as you're looking to have your patients set up for their dialysis care. It's important as we look at the entire community and how we're going to help them further upstream be healthier. But there are a lot of rules, and there's a lot that has to be done to have a patient from a pre-authorization standpoint. It exists right now where you can write so that a pre-authorization can be done automatically, if you will, right? You've put the algorithm in, all the points, all the data points are pulled in, put into the document. But then there's also a learning. When do these documents usually get kicked back? What other information is usually asked? What studies should go in up front? Or, if it actually does come back, an automated process by which it can be reprocessed without bringing you back into the loop until you need to be in the loop. Why is that important? Because your time is not unlimited. You have many different things you need to do. You want to be able to get to as many patients. You want to be able to process as much as possible. That's how you do it, utilizing the generative AI and the agentic AI tools. And then let's talk about patients and member engagement. So we saw earlier firsthand, we all picked a model. We looked at how we would put information in. We looked at how that information would come back. So that could be personalized for an individual patient or a patient population. And we also saw first thing how AI tools were being used to interact with the patient and follow up, to check on them and see how they were doing with the care plan, and also to help them schedule an appointment. That's incredibly important. All throughout the last 25 years of taking care of patients, we've done a lot with value-based care, and we have all these protocols in place. And then the payers came in and said, we're going to help you manage a population. The last part was to activate the patient. Now there's an opportunity to do that, utilizing some automated tools with humans in the loop when absolutely necessary. We saw that happen. That exists right now to be able to use. And what's so amazing about each one of these tools and what's been talked about today in such great detail is how each one of you in your specialty can help to define what that tool looks like so that the outputs that you're getting are helping you to be more successful, helping you to be more efficient, helping you to be able to do what you always wanted to do. None of us ever said we wanted to be in medicine because we wanted to do more paperwork. It was because we wanted to help people. In whatever way you wanted to do that, that was ultimately the reason why we said we wanted to do that. For me, I used to see 30 patients a day as a busy hospitalist, but I wanted to scale that and help to do much more for many more people, which is what landed me in a role like this. And I know for many of you in the room, in your roles that are more leadership and administrative roles now, that's what you're doing as well. So this is real. This absolutely can happen in all the ways that you've talked about today and that you've explained. And our patients will accept us asking them to move a little bit more into this digital world with us as well. My 78-year-old mom, she's not all that tech savvy, but if she wants to talk to her 2 granddaughters, she better answer a text. And so she's gotten pretty good at it. And I know it's true for many of our patients. I want to share this with you. Is anybody familiar with this surgical pod? This is the surgical pod from the movie Prometheus. In it, there's a lead character, a lead female character. She has an alien growing inside of her. She wants it out. She goes to the surgical pod. She dials in abdominal surgery. You can see it on the keypad in the movie. The pod opens. She gets in. There's a splash of betadine. That's pre-chlorhexidine, so it is appropriate for the time. It proceeds to cut her open, retracts, clamp comes down, takes out the alien, puts her back together, staples her, puts a bandage on, she's off. Very quickly. Now, I don't know anyone who's working on this. As far as I know, completely fictional Hollywood. But the idea of it is that if we don't have unlimited human resources, if we don't have unlimited technical resources, financial resources, where can we use the technical resources to expand us? And so for the most straightforward chole or appendectomy, maybe this is the future. If we think about, if we can't get as far upstream as we want to get to take care of renal patients, and we still have the amount that we have right now, and hopefully we don't have more, perhaps there is a renal pod out there. Perhaps there is a way to be able to expand your reach. Perhaps there is a way to reach those rural communities where there are less resources. That's the goal of embracing the technology that we know now. Being able to go from when we had books in our pockets to where we had online resources, to where we had truly integrated at our fingertips digital resources, to truly using this generative AI agentic resources to ultimately get to something that really helps us expand and take really good care of patients based on the best practice and the best known standards so that we can have a workforce that is able to do exactly what they want to do, which is help patients with every possible tool. So thank you.